discuss preoperative and intraoperative decision-making in bariatric surgery, and hopefully Hassan and Bassem will join us soon.
Yep.
So
they both join.
Okay, great. Welcome both. So case number one, this is a 58-year-old male. He's actually Canadian, living in Jordan. He presented to my practice in September 2010, and he had a BMI of 38.5, and his obesity was associated with hypertension, hyperlipidemia, and a new diagnosis of diabetes, more so impaired glucose tolerance. And he did complain of occasional gastroesophageal reflux disease. I actually, before that, I operated on his wife, and we did sleeve gastrectomy for her because she had too many joint issues, and she was going to undergo a knee replacement then, and she was reliant on NSAIDs for quite some time, and he wanted to have the same procedure as his wife. So in general, for patients above 50 in our practice, we ask for upper and lower endoscopy in addition to blood work, psychological and dietary evaluation, as well as preoperative education in before surgery. So I generally would ask the panelists and try to make this discussion interactive. What do you do in your practice for patients, and does preoperatively, and does age or gender play a role in your workup? And maybe start discussing what you do in your practice, Farah.
Absolutely. So similar to you, if folks have pre-existing reflux, we will generally do at least an upper endoscopy. We'll do lower endoscopy if they're of the age where they need colon cancer screening as well. The only role that gender really plays in that workup is for preventative medicine, being up to date, ensuring things like mammograms are taken care of if they need that, pap smears, et cetera. Otherwise, a pure lab workup to ensure their vitamin levels are holding steady. And then it's more of a one-on-one evaluation. What are their medical risks? Are they optimized from a medical standpoint? We do a lot of prehabilitation here, where we do physical therapy up front prior to surgery, so that patients are really moving and as active as they can be before they come to the hospital. And our theme tends to be, if you're active coming in, you're going to be more active going out, rather than trying to learn that after surgery. So that's probably one of the big, I think, differentiators that we've found has been really helpful, especially for our patients that have mobility challenges. Mm-hmm. But further GI workup, as far as for our reflux patients, some of them may get upper GI workup, esophagram, but we don't mandate that if we're going to do an endoscopy with biopsies anyways. So very much matches what you've done.
Okay, great. Firas, meanwhile, Osama, do you want to launch the first poll?
Okay, so we're going to launch the poll for the attendees. We have around 50 attendees with us. Regarding this case, what is your current practice? Which of the following applies to your practice? Routine upper and lower endoscopy to all patients, routine upper endoscopy but selective lower endoscopy, selective upper and lower endoscopy, no endoscopy preoperatively. Can you please, people with us on the Zoom, choose what really applies to your practice in regard to bariatric surgery in preoperative setup?
Firas, what do you do in your practice?
It depends really. While I was at the university hospital, we did mainly GI workup, including the upper endoscopy as a routine. Regarding the lower endoscopy, it was selective. Unfortunately, really, we could not create a proper multidisciplinary team, including the dietitian and the psychologist at that time. Meanwhile, I am working at the private sector, and I am selective in doing even upper endoscopy for sleeve patients, while I do it almost routinely for bypass, because we will exclude a large portion of the stomach, and we have to have an idea about the isolated stomach. But in sleeve, if the patient has symptoms suggesting of GERD, we go for upper endoscopy. Also, patients who is coming for revisional surgery.
So Ahmed, this is the result of the pool. 57% had answered routine upper, but selective lower. And basically not 30% selective upper and lower, and only 7% said no endoscopy preoperatively, and 7% said routine upper and lower. So the majority used routine upper and selective lower. So let's, and I know Ahmed, you have been on the EFSO position statements regarding the recommendation of the routine upper endoscopies for all bariatric patients. Can you tell us more about the statements and why you guys went into this, let's say, strong recommendation from the EFSO position paper?
So, you know, the data for preoperative endoscopy is not solid. But however, if you look at the data that we have, 25.3% of patients, even without symptoms, they will have a finding that will make you change your selection or delay your intervention. So that's a good portion. That's 1 in 4 patients.
But
So
just question, you said change and delay.
Yes.
Is there any, let's say, more specific percentage? What was the percentage that delayed the intervention, and what was the percentage that changed the intervention?
So you
what
have,
is the change? What is, let's say, the change, the percentage that endoscopy changed the procedure?
so the change was around 16%. So it's still a big portion. And you know, if you want to exclude patients with esophagitis, even asymptomatic esophagitis, majority of them were grade A and B, but some were grade C and D, and some had preoperative asymptomatic Barrett's esophagus. And that's a lower percentage, around 1%, but it's still a significant portion, and it may change the outcome of a single patient, which is, to me, if you take it individually and if you offer it to patients, majority of the patients will just say, yes, I want to be safe prior to surgery, prior to a life-changing surgery. And this is a lifelong commitment for patients. Now,
So,
if
Basim, did that EFSO position statement had impacted your practice on routine upper endoscopy pre-bariatric surgery?
My practice in particular, no, because I've been an advocate for routine pre-op endoscopy for a very long time. And I've been doing this routinely for the past 10 years or so. So I'm a strong advocate of preoperative upper GI endoscopy. Now, as far as lower GI endoscopy, I go with what the poll had said, that I do it selectively, in particular patients over the age of 45 or patients with a strong family history of GI malignancies. Now, as far as why do I advocate routine pre-op endoscopy, for many reasons. One is the reported high prevalence of Barrett's esophagus that's reported from many European studies after 5 years of follow-up. Unfortunately, we don't have any data in the Middle East. We have very little data on the prevalence of Barrett's at baseline, and we have virtually no data on the prevalence of Barrett's on long-term follow-up. And that's why we need to establish this. And this is part of what I did. And we've enrolled patients in a prospective database, and we've had several hundred patients now in the study. The other thing that we detect on pre-op endoscopy is hiatus hernia, which is very prevalent in obese patient population. And I'm also an advocate of repairing these during a sleeve gastrectomy. So there are multiple reasons why I do pre-op endoscopy on everyone.
So Hassan, Dr. Basim, Dr. Safadi had mentioned Barrett's as one of the, let's say, findings preoperatively that would definitely change your decision. In your practice, how many Barrett's esophagus you have dealt with over the last, let's say, 10 years, in the last 10 years of your practice? For me, I've never seen a Barrett's in any Georgian patient so far.
Me too, Osama. You know, we don't do upper endoscopies, and I refer my patients to many GI doctors who has been trained in the States and in UK, and they all come to the same conclusion that the prevalence of Barrett's in our community is quite different from what is mentioned in the Western literature. I have dealt with 2 cases of Barrett's, which I doubt they were Barrett's because the pathological criteria were not very solid. But in general, Barrett's for me and the severe esophagitis is something which I probably change my plan for if I'm going to go to do or to select from between sleeve gastrectomy or gastric bypass.
Great. Ahmed, can you proceed, please?
Sure. So this is the patient's workup. This is the preoperative blood workup, and you can see an elevated fasting blood sugar. Hemoglobin A1C was actually controlled while he was on metformin, but a significant insulin resistance and HOMA-IR was elevated. The cholesterol is controlled with his anti-lipid medications, and the thyroid uric acid were actually fine. And if you look at the upper endoscopy, his upper endoscopy, as you can see, going down to through the esophagus. Shortly, you'll see grade B esophagitis, A to B esophagitis, that's mild, a small hiatal hernia, and this, you don't see this in the reports of gastroenterologists. They don't mention bile in the stomach as a significant finding, and I'm not sure if the panelists look at it as a significant finding preoperatively in the bariatric patient population. And you can see the stomach is almost, bile is almost reaching the fundus in this patient.
So I would guess that you don't do your upper endoscopies, Ahmed, from what you have said lastly. That's interesting.
I don't do my own endoscopies preoperatively. I do intraoperative endoscopies, but I refer them to my gastroenterology colleagues.
So Firas, in this finding of bile within the stomach, would it really affect your decision regarding patients who's having bariatric surgery?
Yes, of course. I think having a bile in the stomach indicating there is a duodenogastro-esophageal reflux, or at least duodenogastric reflux. So I think the indication for gastric bypass is more valid in this situation.
So Dr. Hussein, Farah, so do you do your own endoscopies or you refer it to the gastroenterologist? And what do you think bile in the stomach is something significant in your routine preoperative endoscopy?
Yeah, so in our preoperative endoscopy, I should modify. We do them selectively, not because we want to do them selectively, but because unfortunately we have a lot of insurance barriers here. And insurance literally will not cover an endoscopy for just preoperative evaluation unless the patient has reflux. And so it's really unfortunate. We try to do them on as many as we can, but sometimes we can't. With that being said, I like to do as many myself as possible so that we can see that anatomy. And before, something Ahmed pointed out is really important, that bile, I never really thought about it before. But now that I've also scoped so many post-sleeve patients who are having symptomatic reflux, and I look in their stomach and it is often full of bile, and we'll get the pH impedance or their pH study and there's not acid reflux. And it really has convinced me that bile reflux is a very concerning thing in this patient population. And so I think that's a really good observation to make on preoperative endoscopy. We do a lot of informed consent about what this could mean. They want to actually have a pH impedance evaluation to see if they're having non-acid reflux and have that help make decisions as well.
So Ahmed, what is the clinical implication of a long-standing bile reflux? Can you tell us, please?
Well, clinically, you worry about significant reflux, sequela, esophagitis, Barrett's, and potentially the changes that follow. Nobody could predict the actual sequence, but to many, we consider alkaline reflux is more worrisome than acid reflux per se, prognostic-wise over the long run.
Ahmad, don't you think that part of this bile reflux is sometimes a physiological phenomenon? I mean, if this patient is not going to go for a bariatric procedure, would you treat him for this bile reflux, gastric reflux? Do you expect that he will have a long-term outcomes because of the long exposure of the gastric mucosa to this bile? For me, this only indicates that I should be more cautious about looking to the hiatus. I mean, for someone who's doing mini gastric bypass, this is expected even in a gastric bypass, a mini gastric bypass. But I would be very worried to leave behind me an incompetent gastroesophageal reflux. And regarding the way that gastroenterologists report their cases, it's quite different if you are referring them a medical case rather than a surgical case. I refer my cases only to 2 or 3 gastroenterologists who know that what I specifically look for. They have to report the exact measurements of the hiatus opening, the distance from the incisors to the gastroesophageal junction. They have to be very familiar with the findings that will affect my outcome or my decision to go with one or another type of surgery.
Hassan, I do agree with you as far as we do not know the chronological outcome of every patient with bile reflux. I think some of the science is there. The worrying thing is we're operating on young patient population. This patient is not particularly young, he's 58. But if you look at the 20s, 30s, patients who have such finding, what would happen if you offer this patient a refluxogenic procedure over the long run? Nobody knows, especially in the bariatric patient population. But I would be on the safe side, as you said, I would be more cautious, offering these patients something that would induce more reflux. But I'll show you what I did in this patient later on. But Bassem, what do you think?
Well, we are dealing with an entity that we don't understand very well. So bile in the stomach, as Hassan mentioned, is a physiologic phenomenon. We see it on many patients, up to 20% of patients. Maybe that patient in particular, I would say there's a little bit more bile than what you'd normally see. But it's a phenomenon that we don't understand. We don't understand the clinical implications or the pathophysiological implication. So we cannot really base decision-making on this particular finding. What I would do now is just go back to the patient and really spend more time asking about symptoms. How bad are they? Are they nocturnal? Are they disturbing to his lifestyle? And then I would counsel that patient based on symptoms, not much as based on the endoscopic findings. If the symptoms are bad, they're severe, they're disturbing his life, then I would counsel them on a gastric bypass. If not, then I would say I would proceed with a sleeve gastrectomy with a hiatus hernia repair, and I would tell the patient that there's a small risk that the reflux symptoms in the future might be bad enough to warrant revision in the future. But I'll have this discussion with the patient. But I would not base the major decision based on the endoscopic findings.
So I did speak to the patient about his symptoms, and he does not feel any reflux per se. And I usually calculate the severity according to the incidence number of times patients complain of reflux, and if they use PRN medications versus daily medications, and if these symptoms are controlled or not. So this patient takes antacids probably once every 2 to 3 months. So it's not really that significant. And lying down, he does not have any symptoms at all. He sleeps very well, has no issues during sleep time.
So may I add something, Ahmed, just to expand the discussion. So we've always been taught about reflux as something mechanical. So they tell us that there's a sphincter in the lower esophagus, that the pylorus acts as a valve, etc. But we never consider reflux disease as a hormonal disease. But we know, for example, that when we put patients on GLP-1 agonists, if they have no reflux, all of a sudden they have horrible reflux and they have horrible reflux esophagitis. So what if this reflux is something hormonal linked to the obesity? What if the reflux will improve with weight loss? So again, I would not base any major decision on the endoscopic findings because it's an entity that we do not understand well.
So I do agree with you, Hassan. Osama, do you want to launch the second poll just to see, to gauge the audience? What do they think? What
So regarding
procedure
this
you would offer?
patient, regarding this patient for sleeve gastrectomy, would you offer this patient sleeve gastrectomy after all these investigations? Yes. No, I would pursue pH and manometry. No, I would offer Roux-en-Y gastric bypass. No, I would offer omega or single anastomosis gastric bypass. No, I would not offer any type of surgery. Can you please answer? So we have around 50 participants with us. Would love to hear from all of you. What would you offer this patient after all what you heard in terms of preoperative investigation?
So Hassan or Bassem, there's a nice study from the Meester group that looked at the grade of esophagitis to the significance of the reflux. And it's a very neat study. I know the number of patients are quite low. It's 97 patients that they studied, but you raised this issue, and the grade C and D esophagitis always is significant for gastroesophageal reflux disease, but grade A and B does not mean reflux esophagitis or pathological reflux esophagitis, like you said. So in grade A and B, it's less than 80% of patients would have an actual positive pH test. So I actually discussed this with patients and mentioned that, you know, with your grade of esophagitis and the intraoperative finding, it's query. And if you want to be safe, I would pursue a pH and a manometry study. And this patient actually agreed to have a pH and manometry because he was adamant about having a sleeve.
So Ahmed, the results of the poll, it's just quite variable. 35% yes, they would still offer sleeve. 42% no, they would offer Roux-en-Y gastric bypass. 19% they said would pursue a pH study and manometry. And the others are less than 3% no, I would do a single anastomosis gastric bypass. So these are the results of the poll. So Ahmed, what's your rationale about doing the 24-hour pH and esophageal manometry in this patient?
So just exactly what Bassem and Hassan raised. Ultimately, we don't know the behavior of these issues: bile in the stomach, grade A and B esophagitis afterwards. Now, if you want to play it safe, yeah, you can offer this patient a Roux-en-Y gastric bypass. But in patients who are adamant about having sleeve gastrectomy, I would tell them, look, the risk is higher, and the risk of additional procedures, if the reflux gets worse, is higher. Some would, like Bassem said, would get better with weight loss, but some don't really, and the reflux even gets worse after because the data is present, and specifically in him being Canadian, he doesn't behave like us, our patient population, and Barrett's is probably more prevalent in their patient population as opposed to in our patient population. So
Ahmad, what do you think Or how do you think that smoking, which is a very prevalent habit in our community, change your decision? I mean, we have, like, if I'm not exaggerating, 60% of population here in Jordan are smokers. How do you approach them?
That's a different discussion, Hassan. To be honest with you, smoking and gastric bypass are enemies. That's definite, because you're afraid of marginal reflux, and even in patients who quit smoking, the relapse rate is higher and the marginal ulcer rate remains high. That's in Roux-en-Y gastric bypass or one anastomosis gastric bypass. Both are probably the same. We don't have that much data on one anastomosis as opposed to Roux, but the risk is there.
So, Dr. Hussein, Farah, would you do a 24-hour pH in this patient based on preoperative finding an occasional, basically heartburn, as Ahmed said? Is this part of your routine workup in such patient?
I don't think it's our routine workup. I think I agreed with what was mentioned before, that it really depends on how severe the reflux symptoms are. But it is really useful to have this information ahead of time with counseling them afterwards about choices, surgical options. And so if I see this and they're having some symptoms, we will talk very much in depth about the symptoms and how useful it might be to have additional testing. And I agree with what Ahmed said as well, is most patients want to know up front if there's a reason they shouldn't have a surgery and if there could be a possible complication or problem. I hear more often than not them saying, I want to have only one surgery if possible. So I prefer to have the one that seems the best for me. So if possible, I like to get the pH impedance up front if they're having reflux symptoms and I see that bile. It's nice to have that ahead of time.
Okay. Matt, can you proceed?
Yes. So the interesting thing in this patient study, it's not the Demeester score. The Demeester score confirms the pathological severe reflux. But if you look at the data, he had more than 1 hour of reflux while standing, and majority of the time that he was lying down, he had reflux. And the issue is he only had felt heartburn once during the 74 attacks of acid reflux that he had during the 21 hours of the testing. He had only one episode of heartburn, which is concerning in a patient who does not feel reflux. I feel more actually comfortable with patients who actually feel reflux or symptomatic reflux, because you can gauge the severity of the disease based on the symptoms rather than in asymptomatic patients. And if you look at the manometry, this is what a normal manometry looks like. And the most common finding in the manometry that you see with in patients with pathological reflux is ineffective esophageal motility, which may be due to the reflux itself, but that's again another worrisome sign if you want to do a sleeve gastrectomy. So would you still offer this patient a sleeve gastrectomy? I'll go to the panel. Start with you, Firas.
Yes, I think it's a good option. We know that at least 50% of morbidly obese patients, they have reflux symptoms. The problem that sometimes you have endoscopy and you have non-erosive reflux disease. In such condition, I think pH monitoring and manometry study is important or is of value, because some studies, one of them published by Rosenthal, I think they found that around 40% of patients who did a motility study, they have abnormal findings. So it's not the only reflux. Motility or dysmotility, esophageal dysmotility, is common in obese patients. So we have to exclude also the pump failure. So because it will affect the decision for sleeve. You know, sleeve is a high pressure operation. And if you have a dysmotility in the esophagus, this may aggravate the symptoms of dysmotility. For this particular patient, I think grade A esophagitis is a gray zone. You know, it's not an advanced esophagitis, grade C or D or Barrett's. So I think offering sleeve for this patient, especially if they are asking for it, you know, our people and our culture. If you will try to convince them that sleeve is or bypass is a good operation, they will not accept any minor complications in future. So for me, sleeve for this particular patient is a good option. And as we know, sleeve is the most easy operation to convert. I will follow my patient, and if I will have more deterioration in symptoms or esophagitis, I will then offer him conversion.
So Ahmed, I did relaunch the poll, and 63% would offer Roux-en-Y and 40% would still do sleeve for this patient, just to let you know.
Okay. That's a high percent of, would you do routine post-operative endoscopy in those patients? Since this patient is asymptomatic, 74 episodes of reflux without only one single heartburn felt. So would you do routine post-operative endoscopy if you do sleeve in this patient? Bassem, Hassan, Farah, anybody?
Yeah, so the idea of routine post-op endoscopy on sleep patients is something that we should consider standard of care. And it should be done at least 3 years after the first index procedure. And then based on the findings, you would individualize it to either yearly or every 3 years or 5 years, depending on the symptoms and the endoscopic findings. So yes, I think for sleeve gastrectomy, it should be done routinely.
Yeah, for me, Ahmed, in general, for patients even who don't have reflux symptoms before the surgery, I would recommend doing an upper endoscopy study once every 5 years. In this particular patient, if he elects to go with a sleeve gastrectomy, I would recommend him that he will need a lifelong surveillance and he needs to do upper endoscopy once every 2 or 3 years at least. So,
Ahmed, there's a question from Dr. Badr Al-Hadrami from Oman. In terms of this whole issue of GERD after sleeve, and if there is any increase in risk of esophageal cancer, and if there is any data in Jordan patients, are you aware of anything?
Data in Jordan, no. I wish. We have our own data in our patient population. We have a few patients with severe grade C esophagitis post-sleeve that we're still following. A few we converted, but one patient is severely hesitant to have his sleeve done, and he's very happy on medical therapy, maximum medical therapy, and routine surveillance.
So we have a comment from Dr. Taghlib Mazahri. Thanks for being with us, Taghlib. He's another bariatric surgeon at Jordan University of Science and Technology. He says, according to the data that they have at JUST for more than 10 years, they have very low incidence of Barrett's and basically no cases of esophageal cancer after sleeve gastrectomy. I know IFSO had launched an international worldwide survey about the incidence of esophageal and gastric cancer after bariatric interventions. Are you aware of any, let's say, primitive results of this survey, Ahmed?
No, not really. There's a Professor Alfredo Jenko study that he was the first to raise the alarm on asymptomatic Barrett's after sleeve gastrectomy. And he was the first to raise the alarm on 3 of his patients that he continued to follow from the Barrett's population developed, unfortunately, esophageal adenocarcinoma, and one was metastatic, and one had a colon interposition just because the gastric conduit is not there, and succumbed to the sequela of complications of that surgery, and one is surviving. So that's the data that we have as far as esophageal adenocarcinoma in patients who did not have gastroesophageal reflux before the surgery.
So I did actually.
Sama, I think only worldwide, I mean, only 4 published cases or a single case reports esophageal cancer after sleeve gastrectomy. Only 4 publications.
So I did a presentation on esophageal and gastric cancer after bariatric surgery at the Egyptian Society in 2018. And I did really an extensive search of the literature at that time. Actually, for us, around, I think, 40 cases have been, let's say, reported. I did really summarize all these findings. And let's say literally with the thousands of cases of sleeves that has been done over the last, let's say, 20 plus years, if this is really something that is a sort of strong association, would have seen basically a real surge of number of cases. But to be honest with you, development of cancer is much more complex than just simple reflux, Barrett's, and adenocarcinoma. It is, I think, there's a lot of genetic, as you could understand, genetics and environmental factors that really govern the progression of such, let's say, pathway. So I still believe myself that this sleeve reflux, Barrett's, and cancer, I think it's maybe over exaggerated in terms of worrisome, but it's always better safe than sorry. So far, we don't have a strong data to tell if there's any association. But again, there's few reported cases make us really worried about such condition.
Tom, I'm going to make this a little bit more interesting, and I will ask the panelists, when did you do your first sleeve, and which year you think you've reached a peak and steady state? So if you want, I can start by myself. The first sleeve I did in 2006, and I would say I reached a steady state, maybe of a steady volume in 2010. So it's only been 11 years, and I think we should not be kind of cavalier about saying that doesn't happen, because we still need 15 or 20 years to start seeing these esophageal cancers. If we're not doing routine post-op endoscopy on all patients, then I don't think we should dismiss that as a potential problem.
I agree with you, Bassem, and if you allow me, if you look worldwide, we're doing probably hundreds of thousands of sleeve gastrectomies, and it's been reported every year, hundreds of thousands of sleeve gastrectomy worldwide. The unfortunate thing is, if you look at the long-term data, beyond 10 years beyond, we probably don't have long-term data except for 300 plus sleeve gastrectomies in the literature, which is sad, to be honest with you. And if you want to rely on this data going forward 10 years from now, that's sad and unfortunate, especially in the young patient population. So what I would say to patients is, hey, we don't know the outcomes. We're still in the information collection phase, and it's significant for us to help other patients and help you by doing routine endoscopy. You have to, it's an obligation that patients should know that they should be offered the routine endoscopy. And if they want to refuse, it's their right to refuse, but at least you do your part.
So I think, Ahmed, part of the conclusions of this long-term data, they're like, there's the NCBD, the National Cancer Registry database in the States. That's where I think the paper that it was very significant. They had 10 years, let's say, a follow-up of patients who had bariatric surgery, and basically, and they looked at the risks of cancer, and they compared it to those who did not have previous bariatric surgery. And you can tell risk of esophageal. I can share with you the 2 papers that I looked into it. that there's only basically esophageal cancer was less after a good percentage of sleeve gastrectomy compared to the general populations who continued to be obese. So I think, again, it is something we still don't know the definitive answer, but I believe if there is, as Bassem said, his first sleeve was in 2006, but let's say sleeve as an intervention has been there since late 1990s and early 2000s. And I believe if with this hundreds of thousands of cases, if there's some sort of rapid, let's say, progression or deterioration, we'd have heard about it in a much more evident way. Now we are in 2021. That's at least my take off. What do you think, Farah?
Well, I think I agree that part of the dilemma is most of us likely started doing the sleeve again late 2000s. I think I did my first one around 2008. Most of us did not start doing routine surveillance of our sleeve until the last 1 to 2 years, I would venture to guess. I think Dr. Jenko's study did compel us to say something's going on here, but that was probably the most comprehensive follow-up, the sleeve patients that I saw at least. And I think stateside, we definitely did not do routine surveillance for most patients, and we lost a lot of patients to follow up as well. So I think it's very hard to really extract a lot from the data, because I think in our follow-up past 1 year, we see maybe 20% of our patients, if we're lucky. We lose so many of them to follow-up that I don't know that we know the natural progression of the disease yet, because we just don't get them back here, and we don't necessarily have a connected system of finding out what has happened to them down the road. And so you hear about just these single patients, isolated cases that come up here and there. So I do think it's concerning. It's concerning that we see increased incidence of Barrett's in general. And I think we have to start doing that routine surveillance on all these patients and follow them longitudinally to truly understand what the incidence will be in the future. I know my foregut surgeon colleagues are very worried because we did our first colon interposition for a sleeve esophagectomy, for a sleeve esophageal cancer recently, and they're wondering how many colons they're going to have to start putting in chests. And so I think that's a valid concern.
Hassan?
Yeah, you know, I also share the same perspective, but this needs to be weighed against the risk of bypass surgery, especially in mild cases of reflux disease. Bypass is not a surgery without complication. I have seen 2 or 3 patients dying from complication of bypass, internal hernia, small bowel ischemia. This is in comparison to what we know about esophageal cancer, more significant. I mean, I still believe that bypass is more pathological procedure compared to sleeve in the long term. I also would emphasize that we put the risk for the patient in a very frank way. I mean, do we mention to our patient that if he goes for bypass surgery, he has a lifetime risk of 3% internal hernia? He has like 15 to 20% risk of marginal ulcer. He has risk of hypoglycemia. And also, if he wants a revision, this is going to be much more difficult than revising a sleeve. This is all more concerning in mild cases of reflux esophagitis. The things is quite different when we are talking about Barrett or grade D or C esophagitis. But for some patients who have a grade A esophagitis, I would be presenting my data in a very fair way if I'm talking about a sleeve in comparison to a bypass surgery.
I have to echo and agree with Dr. Jalamni. This patient is 58, so we have to weigh in his particular risk, his cardiovascular risk. The risk of developing Barrett's esophagus is different from somebody who's 25. So I would say in this particular patient's weighing in the benefit and risk, I would say the sleeve gastrectomy would be a safer option on him, both short and long term.
I think Hassan is also referring back to one of the studies that just published, and that's been persistent along so many literature and studies that the long-term need for re-interventions after bypass is much higher compared to sleeves at the long-term run. And I think this data has been persistent. Is it part because people don't know how to do a bypass properly? Or is it really an inherent intervention or procedures risks within the bypass. For me, I have never seen an internal hernia after bypass, but you know, I heard we've heard and we've read about all these major bowel ischemia after bypass. What do you think, Firas? Is it because people don't close their mesenteric defects, or it's really a bad procedure on the long-term data?
I wouldn't say bad,
Some
Osama.
inherent risks.
That's a pretty judgmental word.
Okay. I think, Osama, the risk of internal hernia after gastric bypass, as I remember, is around 5%. And the cause is, of course, is leaving the defect open. I had maybe 3 or 4 cases of internal hernias in my patients. And I know I did not close the defects sometimes because it's technically demanding. The patients are super obese, and I took the risk to have internal hernia. And they came with obstruction, and I closed the defects with no bowel ischemia. Winning this case particularly, again, Ahmed, I think sleeve is always a procedure you can convert. So, and we know your patient has a reflux. Around 20% of patients, they will improve even with the sleeve. We know, and 80% will have persistent symptoms. 5 to 10%, they will have aggravated reflux symptoms. In those patients, you can start medical treatment, and then if it's ineffective, and as mentioned by Dr. Bassem, the patient is young, you can offer him then a bypass surgery.
So just to enrich the discussions, Dr. Badr al-Hadrami from Oman, he said that he had encountered 2 cases of young patients of esophageal cancer after sleeve gastrectomy, young in their 30s, with symptomatic GERD. So symptomatic GERD, offered sleeves, and ended up with esophageal cancer in their 30s. This is very interesting, Badr, and I hope you have reported these 2 patients to the EFSO survey. To all panelists, Dr. Taghlib Mazahir is asking, do you think lower esophageal cancer had a bad prognosis after sleeve in compared to those who did not have sleeve? What do you think, Bassem? Bassem, we can't hear you.
Sorry, I said esophageal cancer is bad no matter if you had a sleeve or not, and it depends really on when you detect it, if you detect it in the early phase or the late phase. With the sleeve, definitely the operation will be technically more difficult. And when the operation is technically more difficult, then complications are higher, and then the risk of succumbing to complications is higher. So I don't have data, but intuitively, I would say if you had a sleeve and had esophageal cancer, you're in trouble.
Ahmed, can you proceed, please?
So let me just mention a few things since you raised the issues of internal hernia, hypoglycemia, and Roux-en-Y gastric bypass being sort of a bad procedure.
I do a lot of bypasses myself.
Yeah, no worries. But you hear this statement even from pioneers. I've heard Dr. Hempens state in the World Congress of IFSO, he calculated the number of mortalities post Roux-en-Y gastric bypass versus the number of potential esophageal cancers that could develop after sleeve gastrectomy, given the data. So it's there, the argument is there. But let me tell you this, we know that internal hernias do occur, and the percent can be less than 1% and can be up to 14% if you don't close the defects. If you do close, you still can develop an internal hernia. But if you follow up your patient and investigate any abdominal pain post Roux-en-Y gastric bypass and take care of the patient, do a laparoscopy and close the defects, then your patient is safe. Get this, there's a paper that's going to be published soon hopefully within the next 1 to 2 months, that is posing 15-year outcomes post-sleeve gastrectomy. And those patients, 50% of them had undergone conversion to other procedures. So if you have that data, would you still talk about sleeve gastrectomy the same way you're doing this? That's one. Second, the issue of weight loss after conversion of sleeve gastrectomy. Very little data. The outcomes of convergence post-sleeve, if you look at the data out there, they're quite poor. Even if you do second stage DS. Second stage DS years later is not the same as if you plan to do it first stage. So this is what I did with my patient. So I rely on data, and we're part of the MBSA-EQUIP registry. And I present this chart to patients. So this is your risk based on a large number of population. And MBSA-EQUIP is used in the US, Canada, many sites. And if you look at the complications, yes, sleeve gastrectomy, any complication, Roux-en-Y is probably more. Any complication, serious complications, sleeve gastrectomy is less. That's short term. Leaks are almost similar. Bleeding is more. Surgical site infection is more. But look at the benefits. Weight loss, that's MBSA-EQUIP data and not my, not only my data. Weight loss is better over the short term. And if you look at remission of his associated medical issues, higher remission from hypertension, higher remission of hyperlipidemia, higher remission of gastroesophageal reflux disease, and higher remission of diabetes. So, and this is our data in regards to other sites, and I share this with patients just to reassure them that our data is also quite similar to the MBSA-EQUIP registry, looking at all complications and readmissions and everything else. And if you look at erosive esophagitis in asymptomatic versus symptomatic, and this is a paper that even new onset asymptomatic erosive esophagitis is high, but non-erosive esophagitis is high as well. This is short-term data. I want to see more and more long-term data, and the recent long-term 15 years outcomes, which hopefully will be published soon. You look at how much reflux is out there and how many conversions in the sleeve population is there. So eventually this patient, given my bias to Roux-en-Y gastric bypass, underwent a Roux-en-Y gastric bypass. And I know it's inherent in every surgeon. Whatever you're comfortable in, you're gonna be lenient towards that procedure. But if you take yourself away and follow up your patients and collect your data, then you'll know what to do best for patients and how you can take care of those patients best.
Great. I just would like to add a comment from Dr. Yasser Rayyan. He's the dean at the University of Jordan Faculty of Medicine. He's an experienced gastroenterologist. He said, I think we don't have a clear data to connect sleeve to adenocarcinoma, but de novo reflux or persistent reflux or worsening reflux are more clearly defined with sleeve gastrectomy. An improvement of reflux is rare based on his experience, and he would offer a Roux-en-Y gastric bypass in any patients with GERD. Thanks, Dr. Rayyan, for being with us. So, Dr. Farah, would you agree of what Ahmed had done in this patient?
Yes, I would. I think it was very appropriate to offer this patient a Roux-en-Y gastric bypass.
Great. Basim?
Yeah, very appropriate choice. But I would also add that I would fix the hiatus hernia as well.
Great, great. So, Ahmed, for the sake of time, we have only 3 more minutes. Can you tell us what exactly happened?
So I did basically Roux-en-Y gastric bypass.
Okay, a lot of 12
in this patient.
trokers in this.
Yeah, I use 412s and one liver retractor,
Okay.
5 millimeter liver retractor.
So you start at the.
I start at the left cruise, define it, take away the fat pad, and basically finding a significant hiatal hernia there, I would fix it. And in that patient, basically, in all patients, I create my pouch first, majority of the time, and I do a short 4 centimeters from the GE junction.
So you use black, Ahmed?
Depending on the thickness.
Okay.
In this patient, yes. The first 2 firing.
Okay. Any issues of postoperative bleeding with all these thick black and green?
I invert all my staple lines.
Okay.
So that's something I learned from my time in the fellowship. We had 3 patients who came back with, after a hematoma with staple line failure, sepsis, and PE at the same time. So you have a patient who bled with PE and staple line failure, and that it was the initial launch of the Echelon Flex. So part of that technology was an issue, probably.
Hassan, I know you are most of a single anastomosis gastric bypass. And this patient, if you are going to offer him a Roux-en-Y gastric bypass, what are the limb length that you look for? Hassan, are you still with us?
Yeah, generally, I would take like 30% of the total small bowel length and divide it between the pilopancreatic limb and the Roux limb. So in this patient, what was his BMI, Ahmed?
38.5.
Yeah, an average a total small bowel length of 600 centimeters. This means I probably would offer him 1 or 100 centimeter pancreatic limb and 100 centimeter Roux limb.
So you just opened a huge area of controversy and discussion whether to measure or not to measure. Farah, do you measure all your bowel length when you're doing bariatric bypasses?
Not on my primary cases. Generally, I do on anyone revisional who's seeking additional weight loss, and I like to use the percentages in that case. I do find it compelling, though. I think it's an area that we also need to explore further. Are we doing a service to people doing the same Roux limb and biliopancreatic limb lengths on every patient when the patients aren't the same? Should it be more of a percentage to truly induce the metabolic changes? So I don't do it yet, but I could definitely be convinced about it.
Okay. Ahmed, can you wrap things up, please?
Sure. So in this patient, eventually did a Roux-en-Y. He did well so far. He's almost a year out, and actually he's beyond 1 year. He had his 1 year follow-up recently, and he's doing fine.
Great.
Well, I would urge just the thought of if you have a question, offer your patients additional workup. pH manometry can help you gauge your decision-making process, and it's it's better to collect more information rather than just to sit tight on your patients.
Great. Well, I'd like to thank you all, Farah from Oregon, Portland, Hassan, Bassem, Firas, Ahmed. It's been a great night and a great discussions about these controversial issues. Thanks again for being part of this Jordan Surgical Grand Rounds. Any final comments from Farah, Ahmed, Bassem, Firas, and Hassan, please? Farah?
Thank you very much for allowing me to participate. I think these discussions are wonderful, and we need to keep exploring all of these questions that we have in our field. So, and Ramadan Mubarak to everybody.
Thanks, Ahmed.
Thank you, Osama, for the opportunity. And you know, the one thing I would urge is keep an open mind and keep looking out for the data out there and help us collect more data, definitely.
Great. Bassem?
Thank you very much, Osama. Thank you, Ahmad. And again, I just wish everyone Ramadan Kareem, and thank you for a great discussion.
Thanks, Firas.
Thank you, Osama. Thank you, Ahmed. كل عام وانتم بخير جميعا.
Ramadan Mubarak. Hassan.
Thank you, everyone, and I really enjoyed it. Although it wasn't the very good time after 1 hour of iftar, but I really enjoyed it. Thank you.
Thank you very much, guys. Good night, and we'll hope to see you soon. Thank you very much. Assalamu alaikum.
Thank you.
Bye
Thank you.
bye.